so that we can have it for longevity. All righty. I'm going to share my screen. And I share my screen with my PowerPoints only to keep me on track. So we're going to, I hope that you looked at the key terms in the beginning of your chapter, because those are things we're going to discuss. Those are highlights. And I love your book, because once again, it tells you exactly what page is on even. Isn't that great? So I said, that's really fantastic. So I hope that you're creating your own HESI review of the terms by doing key terms each week. By the time we get to week 10, you'll have a nice HESI review. Okay, you won't need anything else, but well, anything else with that, with terms. All righty, share my screen, and I'm going to discuss now chapter 5. All righty, gotta bring this back up, but I'm not the end yet. All righty. So like I said, we're going to discuss the complications that occur in pregnancy. And we're going to discuss the different diagnostic tests, like an amniocentesis test. These are with complicated pregnancies. I'm going to identify methods to reduce a woman's risk for antepartum complications. Remember, nurses, you're going to be a nurse. Nurses always critically think ahead. And I'm always thinking, what are my risk factors and how can I keep her from getting complicated, from getting into the high risk? I want to prevent her, guys, from getting sick. I really do. And then we're going to describe her antepartum complications, their treatment and nursing care. So some characteristics, causes of high-risk pregnancies. All right, so maybe, she came into the clinic with already a chronic condition. She may have chronic hypertensive disorder. She might have already diabetes. These are all conditions that what complicate a pregnancy. How about advanced maternal age? Does that complicate a pregnancy? Yes, it does. It sure does. Environmental hazards can complicate a pregnancy. There's teratogens out there in our environment that can be hazardous to the fetus. And of course, we talked about lifestyles and how they have a negative effect. So it's nice when a woman comes in and she's really healthy, but there's not too many people out there like that. Nursing responsibility. So you are the nurse, okay? You must always, 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 doesn't matter if it's maternity or med-surg, you prepare the patient properly. You don't ever do a test on a patient without explaining what's going on. That's called assault, actually, when you do something on someone else without them even knowing you're doing it. And then clarifying and interpreting results in collaboration with others. I'm going to tell you, ever go to a doctor and I know my own mother would say, I want you to come with me to my doctor's appointment. Why? Because maybe he's just going to get a test result. And what happens? What happens to a person that's sitting in that chair and they're getting a test result? It goes right over their head. So we as nurses are always the ones who are interpreting results. We are working with the doctors deliver the initial message, but we're the one picking it up, correct? Have you ever been in that boat? I have many, many times. Patients would be sitting there going, what did the doctor say? And I would sit down and face to face, eye to eye, and talk to the patient. Okay. All right. So here are your danger signs in pregnancy. These are really, really important to learn and to keep it in your head going, Sudden gush of fluid from the vagina. That's her bag of water. Okay, so if you're premature, if you're a 26-weeker and already had a gush of fluid from the vagina, that's a danger sign. Vaginal bleeding. You could have early bleeding, early trimester bleeding, and that would be maybe she's going to have a miscarriage or she's going to abort this baby. Okay, all right. Late vaginal bleeding, late pregnancy, that would be your placenta previas and your rupture placentae. So again, vaginal bleeding, it is a danger sign. Abdominal pain. Yes, abdominal pain, other than say contractions. It could be that she's having cystitis, she's having a gallbladder, or she has epigastric pain. That's a severe sign of preeclampsia. Persistent vomiting, that's your hyperemesis gravidarum, that's persistent. That's way beyond just a nausea vomiting that lasts up to 14 weeks gestation. And so that's never good because why? The patient is getting dehydrated. Her electrolytes are getting off normal. If she goes real low on potassium, it can affect her heart, and affects mom, it's going to affect the fetus. Okay, I already talked about epigastric pain, edema of the face and hands. That goes along with swelling of the hands and face. And that's preeclampsia. Severe persistent headache. Now, guys, this is a headache that they come into your clinic, they're holding their head. Now, watch me. See my head? I'm holding my head front to back. This is how they walk in the clinic, and they say this is a headache that just does not get relieved by Tylenol. Blurred vision or dizziness. Again, this goes in with preeclampsia. Chills with fever over 38 Celsius, which is 100.4 Fahrenheit. Guys, that's a fever. Okay, could be from cystitis, and now we got polynephritis. Painful urination or reduced urine output. Again, that's very indicative and can throw her in. It's very, very important. We know this because she can go into preterm labor really, really, really easy. So remember, you got a fetus in here. This is mom's hope, mom, and every organ gets affected by pregnancy, every organ. Okay, so here's my first test we're going to talk about, and this is called the amniocentesis. It's removing amniotic fluid from the uterus. So you can see here on this little diagram, here's your fetus, and you have to wait at least 12, 13 weeks into the pregnancy, maybe longer, because you have to have enough amniotic fluid. Because you have to, this fluid, we have pockets of fluid, and we go in here with this syringe and a long needle. It's like a spinal needle. And we go right into the uterus to get the amniotic fluid. Okay. It has a lot of risk. But reason why we do that, especially for our high-risk moms, age 35 and above, maybe they're in the 40s, and we want to do a chromosomal analysis. Write that down. The amniocentesis done in the first trimester is done for chromosomal analysis. That's the guaranteed way of knowing exactly if this baby is normal or abnormal. And a lot of older women go for this. Now, it has its risk, because anytime you're going to go into the uterus, it could definitely irritate the uterus and make it start contracting. So she could have a miscarriage. So again, it is with risk. And so usually after we get done, we have the patient lie very still. And we're going to monitor for contractions and for any vaginal bleeding.
I have a question, Professor.
Go ahead.
Is it done by a nurse or by an anesthetist?
Yeah, it's done by an obstetrician.
Obstetrician.
Yeah. But what nurses come involved is the care, of course, before and of course afterwards. And then you're with the patient and you have ultrasound guidance. You have another person in the room who's doing the ultrasound, and this is done under ultrasound guidance. Okay, because what we do is we look for these pockets of fluid, and we keep away from the fetus itself and just go for the fluid. And usually they fill up like a 20 cc syringe and send it off for chromosome analysis. It's a really good test, but it does come with its risk. And we're looking for fetal genetic diagnosis. So, you have to wait until there's enough amniotic fluid. So that's like a negative to it, because you have to wait. And if it is abnormal, then the woman can base her decision either to keep the pregnancy or to abort the pregnancy. So now I told you to write that down, that use that this amnio is in the first trimester for chromosome analysis. We can also use the amniocentesis later in later pregnancy, say the last trimester, when I want to evaluate fetal lung maturity. So for instance, I may have, say, a 28-weeker, okay? And it looks like we're going to deliver, or we might have to deliver because of preeclampsia. I want to know the status of those fetal lungs. I want to know if the baby has enough surfactant in the lungs to let it go inspirate and expiration. So they might do an amniocentesis at that time to evaluate fetal lung maturity. And I'm looking for the LS ratio. So I know HESI, and we'll discuss about LS ratio as we get down into newborn, but I know HESI likes to put questions like that. So you would have to make sure that you read the question very carefully. Are they asking me about amniocentesis in the first trimester or in the last trimester for fetal lung maturity? So these are your pregnancy-related complications: hyperemesis gravidarum, persistent vomiting. Really, really, a lot of ladies get this, and it does not end, folks. It goes all the way to term, all the way to delivery. And let me tell you, I had a patient that suffered with hyperemesis gravidarum, okay? In her labs, when she came in, her lab work was really off, and we had to, rehydrate her and get her back on track. And then she pushed, she was in labor at the same time. And so we got to be complete. Okay. She threw up a lot during the labor. We got to complete, and I asked her to push, and she was pushing, but she wasn't having much success, and she was really tired. So all of a sudden, then she had to throw up again. And as she was throwing up, it moved the baby's head down really nice. So she delivered throwing up, but it worked. I mean, it worked. But again, hyperemesis gravidarum goes all the way through the pregnancy. It's a rough pregnancy. They're in and out of the hospital quite a bit because of electrolyte imbalance, the severe dehydration. They can't, and don't forget, if mom's not taking in nutrients, the baby's not getting the nutrients, correct? Yeah. So babies is going, hey, in there, I need something. So a lot of times in the real severe cases, we have to do TPN, which is total parental nutrition, and they have to put a tube in and feeding tube in, and that will work. Okay. Now we're going to talk about we're going to talk about bleeding disorders: early bleeding, which is your miscarriages, and late bleeding, which is your placenta previews and abruptios. We'll talk about those. Hypertension, we're going to get to with preeclampsia, eclampsia, and then your blood incapacity. Okay. All right. Anybody have a question?
I do.
Go ahead.
For the amniocentesis, you said that it was most common in those with like a high maternal age.
Yeah. Yeah, they advanced maternal age. Say a woman, 35 and above, she comes in, she's pregnant for the first time, and she's a little nervous, and so she says, well, I want to make sure my baby's okay. She doesn't want to wait for the alpha fetal protein test, which is around week 16. So, because don't get week 16, you're getting closer to viability. So they say, well, what other tests can I have? And we say, well, you can have an amniocentesis, where we can get we can get a little bit of fluid and send it off a chromosome analysis, and then you can make your decision based on what the results are. So a lot of older ladies go for that. As I said, there's another test that's done about 16 to 18 weeks gestation, and that is called the alpha fetal protein test. And that test is only a screening test. Only a screening test. If that comes back positive, then we go with an amniocentesis, because that is what we call that, the cream of the crop. That is the Cadillac or maybe the Lexus of tests. It's a good test. It really is a good test. Though it comes with risk. Absolutely. But, versus, baby born with an abnormality that maybe is not conducive to life, or it could be a Down syndrome baby and they just, they don't want that. We make the patient and their family make up their own decision. Okay. Hyperemesis, like I said, excessive nausea and vomiting. Okay. There is a question on exam number 1 on hyperemesis gravidarum. And it's just dehydration, electrolyte imbalance. It can impact the fetal growth. This is where you get a lot of SGA babies or IUGR, intrauterine growth restricted babies, IUGR babies, because mom just doesn't get the nutrients that she should get. And don't forget, remember how many extra calories can mom have or should have during the pregnancy?
300.
300. So if she's not even getting in anything, then she and the baby are going to be greatly affected. You can see that. So again, what's our treatment going to be? Well, we're going to give her hydration. Okay. Antiemetic drugs, Zofran, Reglan are the ones that we use a lot. And we use them cautiously, especially when you're dealing with pregnancy, and only if they need to be, only if they need it. And it usually works very well. Now, I've had patients come in very, very sick, very, very sick, and very fatigued, and get very depressed even, because imagine vomiting all the time. It's horrible, and so they get very, very, they can get down on themselves. So the next disorder I want to talk about is types of abortions. Okay, so in your book, there's a really good picture, and this is like right from your book. I stole it from them, actually Elsevier. And then here, so here I want to go over, these are what we call spontaneous. They're not, when we mean spontaneous, we mean that they're not intentional, okay? So like a threatened AB is one that would have, maybe she has a little cramping, maybe she has a little spotting. And so she just has like, here's a picture. I love this picture. Here, the fetus is intact. The bag of water is intact. And she's just having a little bit, the cervix opened up and having a little bit of vaginal bleeding. Okay, that's threatened. So what we're going to do is we tell her bed rest. You're going to go home, and strict bed rest, and nothing in the vagina for 2 weeks, nothing. And so what happens on these, it does seal up very nicely. Those are threaded. Now this one here is inevitable because what happened? The bag of water's broken, she's bleeding, and the cervix is now opening up. See here the cervix, how it is open, and all of this is coming out. I cannot, guys, I cannot stop this from happening. It's gonna happen. It's gonna happen. And it's sad too. It's very sad. I just had a friend that lost a baby at 16 weeks gestation, and there was just nothing anybody could do. And so she's going through the grieving process right now. Now this one over here is incomplete, where some of the products have been expelled and some are still in that uterus. Well, we can't leave this, okay? So this patient's gonna have a curettage. She's already dilated a little bit, so we might have to dilate a little bit. So that's called a dilatation and curettage. And we go up in here, and it actually looks like a vacuum. And we're going to evacuate this whole inside of her uterus. We get rid of all this so that she can have a couple cycles and then get this endometrium replenished for her to try again. So these are your different types of ABs and what happens to them. Now, when you have an induce, that means it's a more of elective induction or it's more intentional. It may be because the baby is incompatible with life. Remember I told you she had amniocentesis. They found out that there was something wrong with the fetus, and so they had opted now to abort this baby. So we at the hospital, we had to present her case and her lab work and her ultrasound and her amniocentesis results in front of the ethical committee in order to we present our case to tell them why we need to do this elective AB. So that's what happens in the hospital on that. Now, early pregnancy bleeding. Again, she comes in and she may be a threatened. I'm going to always, guys, you always want to describe and chart the amount and character of the bleeding. Do you have clots? Did the specimen, did it look like tissue? I've had women that came in and they had like a little jar and they had the tissue in the jar. And then we send that off to pathology. Now, if we do a D&C at the hospital, then all those products of conception, if say she had this here where she had incomplete, and we're going to go ahead and evacuate all this out, we collect that. It looks like a little net, and we send that to pathology. Pathology will examine, and it's called the products of conception, and confirm that yes, they are products of conception. So we do that. Also, if she goes home, you know, she comes in and, you know, she's not complete yet, and she's just starting, maybe then we'll go ahead and send her home with a jar. And when she goes to the bathroom, she passes the tissue. We asked her that to get that, and she brings it into the office, the clinic, and we send it into pathology. Now, anytime that a woman is actively bleeding, she should be kept NPO, because just in case you want to do that D&C, okay? You know, you have to think ahead, say, you know, so she calls you and she's telling you she's actively bleeding and she thinks she passed some tissue, but not all of it. And she's going to, you know, tell her to go to the hospital, and they meet her in the ER. Tell her, do not eat anything. Do not drink anything, because anesthesia will not administer a general anesthetic to anyone who's had anything to eat or drink. And you don't blame them, because if they did that, she could aspirate, and that'd be very bad. So that's your role as a nurse, to think ahead, always thinking ahead, okay? And when you think ahead, you're critically thinking, and you always want to make sure that, you know, you don't eat or drink anything. Come to the hospital, bring the specimen, and then we go on from there. What do you have to teach afterwards? You know, after they pass the fetus, and you go home, any increased bleeding, temperature. Temperature is so important. You take it every 8 hours for how many days? 3 days, okay? And then you already did some blood work on her, so you know if she needs an oral iron supplement. So if she needs some extra help on that, you give it to her, because she could lost a lot of blood, okay? And then they resume sexual activity. You know, we usually try to get at least a couple weeks. You know, don't have anything in the vagina for a while. Let your body recuperate from the D&C, and then you can start. And usually I try to tell patients, at least have one complete cycle. You know, a normal cycle, because a menstrual cycle after a D&C could be a little lighter, could be off. So then you would wait and wait for the next cycle, and then make sure it's a good cycle, you know, and then she can resume, you know, her activities, and she wants to get pregnant again. We're nurses, and so you have, guys, tremendous responsibility of providing comprehensive discharge education. You know, you don't want a patient coming back and saying, well, the nurse didn't tell me. What do we have at the hospital that we actually created so that you know, that doesn't happen? We have those discharge instructions. I know. If you've been in a hospital or you've been to clinicals, or, or you haven't been yet, be sure to look at those discharge instructions. They're comprehensive. And sometimes people are like, okay, I want to get done. I want to get this done because I want to get out of here. I'll say, no, I want to make sure that you understand and you're going to sign this, so that, they can't say, well, you didn't tell me. Okay. So let's see. Here's our first little brain teaser. Mr. Brainy up here. He's saying hello to you all. You have a woman who's 8 weeks pregnant, and she calls in to report cramping and a small amount of vaginal bleeding. What conditions should the nurse consider?
B.
B.
D.
B is correct.
B.
She's a threatened. So this is what I did for you. I'm telling you here, she's 8 weeks and she has a small amount of vaginal bleeding. That's your clue. So a small amount of vaginal bleeding would be a threatened abortion, because placenta abruption doesn't go with that. That comes out after 20 weeks. So that one's out. And it's not a complete because she's still pregnant. Okay. And it's not a previa because, again, that's after 20 weeks. So threatened AB. Okay. So you can see how the question would be. That's why you must read these questions carefully. All right, let's go on. Let's talk about another complication. This is called the ectopic pregnancy. That means the poor little guy, that zygote, got stuck in the fallopian tube. Maybe due to some scarring, there may be some other kind of deformity of the tube, may have adhesions, okay? She may have a condition already called endometriosis. And there might be some congenital defects with this to begin with. So it gets stuck in the tube. So 95% of ectopics get stuck in the tube. And here's my little picture. So you can see, here's your ovary, and here we have the vertebrae again, and here we have releasing. Here she has you have fertilization, and here he's trying to make his way through the tube. But guess what? He gets stuck in the tube. All right, he should make it. Well, this is just different sides of ectopics, but most of them. Let me tell you this again: 95% occur in the tube. Now, this tube is not big. It looks big on this drawing, but it's not. All right. So for a little zygote to get stuck, it's not that easy. Won't take much, and so it gets stuck. And so she has, what your patient will exhibit is pain. She'll call you on the telephone. You may be the triage nurse, and first question you're going to ask her, when was your last menstrual cycle? And so she tells you, oh, I had it 8 weeks ago. Well, bingo. And where's your pain? Right lower quadrant pain. And it's intense. And it doesn't go away, nurse. What are you going to tell that patient to do? You're going to tell her to go to the hospital.
Go to the ER.
Yeah, the sooner she gets to the emergency department, the better. Because you don't want her to lose this tube. Okay, so you get her to the emergency department. They do a quick ultrasound. They see that she has ectopic pregnancy, because it's rapidly cell dividing while in the tube. Right here, it's rapidly cell dividing. It doesn't know to stop because it's stuck. So it keeps going. So it means it's getting bigger and bigger and bigger and bigger. And so that's why it gives her so much pain. So we get that, and we get it early enough, we can give her methotrexate, which is medication that we use for cancer patients to get rid of those cells. So we give her methotrexate. This is done by an RN in outpatient surgery. And we tell her again, she's going to the hospital, don't have anything to eat or drink, because we don't know exactly what's going to happen there when she gets there. And they're going to give her the medication, and the methotrexate will target, what it does when you give it, it targets the cells. Okay, it knows exactly where to go. Angel, you have a question? So it goes exactly over to the cells, and it breaks up these cells, and then the body will reabsorb it. Well, that's great, because what happens is that you save this tube. Now, say, on the other hand, she didn't call you, and now all of a sudden she goes to the ER because now she's in a lot of pain, and they find out that she did have an ectopic, but it's ruptured. Okay, that means that the tube now has dehisced, has opened up, and so she has to have surgery, laparotomy, and they're going to go ahead and they remove this tube. All right. When you do that, you decrease her chances of getting pregnant by 50% because now you remove the tube. So you try to make sure that when you got a patient with an ectopic pregnancy, that you get them to the hospital as soon as possible so that the tube does not rupture. Okay. And then this slide here just goes over exactly what I just said, so I won't repeat it. So with ectopics and with the abortions, either a spontaneous abortion or an elective abortion, you're losing a baby. And so these families go through tremendous grieving because they lost a baby, no matter what it is, and they have to grieve in order to resolve, to move on.
I
Okay.
had a question.
Sure.
If 95% is in the fallopian tube, then where are the other 5?
Oh yeah, let me go back to that slide. I can show you. These are some other common sites. These little cells can go into the mesentery, as you can see here, the gut. It can make its way down, but it implants by the internal os, which is really, really low. Or you can have cervical implantation in the cervix. You're dealing with body fluids, you're dealing with active cells. Cells are always moving inside your body. So this is what can happen. Yeah, they can go to places. So not too many times that you see it other than the tube. Really, in about 50 years I've been in nursing and women's health, and all of my topics that I've ever experienced have been in the tubes. Okay, but you're dealing with a living being, with lots of fluid, and cells mutate. They're always ever changing, and they can travel. Okay, so let's get out our thinking caps, and this is a really important slide, as you can see. And these are signs and symptoms of hypovolemic shock. Okay, so when you have a med-surg patient, they can go in shock, right? When anybody that loses a lot of blood goes into hypovolemia, low blood volume, they get, the first sign you would see in a regular patient would be a tachycardia. They have a very weak pulse, but it's rising. So you get tachycardia. You also get tachypnea, because this person's trying to breathe, but he doesn't have much circulating in his circulatory system. There's not much blood. Blood has oxygen. This guy is trying to, so they're going to work really hard, so they're going to have rapid respirations. And they look as if they're like air hunger. They're very shallow and irregular respirations because they're trying their hardest to get air. And we call that air hunger. And then the heart rate is going high, but now my blood pressure is going down because I'm losing blood. I'm hemorrhaging out. We see that a lot in postpartum hemorrhage. So you have a low blood pressure. Now, when the body is sensing that something's not right, okay, it sends blood to the vital organs, which would be your heart and your lungs, okay? it sends the blood there, so it'd be shunted away from the uterus. It's also shunted away from the kidneys. So that's why you get a low urinary output. So that's why when somebody is in hypovolemic shock or hypovolemia, you want to make sure that you're looking at the kidney function. So you're going to measure. So usually if you get decreased urinary output, that's usually less than 30 mLs per hour, because that's your guideline is, make sure those kidneys are working. Because if kidneys don't work, they shut down, then you're in real trouble. And so then they can lose their kidney function. All right. And then after all that, you'll see pale skin, mucous membranes in the mouth, that's a quick way to know somebody's really hemorrhaging, is it'd be very pale. Okay. Pale mucous membranes. And then the skin is cold and clammy, and of course, patient is kind of fainty and thirsty. So these are like minimal to me when I have all this going on and I see my patient maybe with a pulse rate of 120. I got a blood pressure of 70/40. I have tachypnea. His respirations are like 40. His breathing is shallow and irregular. We got a problem. We are in bad shape here. And that person is either is going to code on you. It's going to go. Now, with pregnancy, you add in, guess what? You got to look at the fetal heart rate, because I got a little baby inside. So mom's having problems as it is. Baby's going to feel it. So baby, it can either get very tachycardic before they may plumage down, before they decrease, or they can start with very low heart rate and then they'll go down. So you'll see that they would have no variability. Okay, that means those squiggly lines would not be there. They would have no variability. So that's a bad sign too. Okay, so keep in mind, this goes for any patient that is having a hemorrhage. You have a gunshot wound, okay? They're going to bleed out on you, all right? So if they're stabbed, they're going to bleed out on you. These are patients that can go into hypovolemic shock really, really, really fast. Okay. All right. Now, remember, we talked a little bit about hydeniform mole last week. It's also known as gestational trophoblastic disease. And also I mentioned to you, it's also known as molar pregnancy. So I got a good picture for you. This is of hydeniform mole. See what I mean? It's a bunch of cells, okay, that just kept multiplying. They didn't know to stop. So they're multiplying, and her HCG levels will go high because there's such massive amounts of cell division, but there's no heartbeat. Now look at this picture real close, and you don't see any kind of formation of a fetus. This is a molar pregnancy, okay? It can cause a hemorrhage. It can cause her to have severe clotting abnormalities, hypertension. And then later, I told you in life, she would have to be looked at very carefully because of development of cancer in the woman's body. So these usually occur at, age extremes of the reproductive life. So again, that first ultrasound that's done at 10 weeks, like 8 to 10 weeks, is important because I need to see that heartbeat. See, I'm looking for the fetus, but I'm looking for that heartbeat because I don't want to see this. This is a hydeniform mole. All right. Again, what's your treatment of hydeniform mole would be, I have to do a dilatation and curettage. I have to clean out, evacuate that uterus, okay? And she cannot, write this down, she cannot get pregnant for 1 full year. So got to talk about birth control with these patients, and very serious birth control. Her HCG levels have to They normally get very high with this type of pregnancy. And so they have to come down, have to get it back down to 0. So that's why you need that time to get those HCG levels back. Okay. And also, a patient who has severe hyperemesis gravidarum in the very beginning, you want to get that ultrasound too, because hyperemesis have been associated with molar pregnancy. Okay, all right. And another thing too is because there's so much cell division going on and it's rapid, her uterus gets larger than dates. It's much larger. So say she's supposed to be 10 weeks, she comes in and you lay her on the table to do an ultrasound and she's looking like she's 20 weeks. She has the very large uterus because again, this just keeps dividing and multiplying. Okay, so that's a molar pregnancy. So now we're going to go into a complication of bleeding disorders of late pregnancy. So we're going to talk first about placenta previa. Okay, just like the words sounds, it's a placenta that is first. Previa is presenting first, and it shouldn't be. Placentas are supposed to be up on the on the uterine wall, right into the decidua, and the placenta is low. It implants itself real low, and it can be marginal or it can be a complete previa. Okay, marginal is about 2 centimeters, approximately 2 to 2.5 centimeters from the internal os, and a complete, this placenta is laying right over that internal os. So what's presenting first? Previa is the placenta. Okay. Now her bleeding on this one, it's going to be bright red because you can see there it's just a short passage without blood to go through, and you'll see. So that's why you would see bright red because it's fresh. Okay. So you have bright red bleeding, and it's painless. Write that down. So I would write down placenta previa, painless, bright red bleeding. Okay. And this happens when that cervix starts to open up, and then you got a previa. Okay. So, years ago, we used to put these patients in the hospital all the way from the time they started bleeding all the way to when she got to be close to term. And then this kind of patient, guys, have to have a cesarean. You cannot get a vaginal delivery. And all the hospitals I worked at or consulted with over my many years, we never did a vaginal delivery on a previa. Okay. Now you say, well, marginal, maybe you can deliver there. You're taking it's a high risk because the marginal placenta is about 2.5 centimeters from that internal os. You're getting really close, but you don't want this lady to have contractions. Placenta previa, when a person has placenta previa and they contract, they're in labor, you're going to have a hemorrhage. So this patient's going to have a C-section. Okay. Everybody got that? So I'm going to ask you a question. So the pregnant client has a diagnosis of placenta previa. So when reviewing interventions with her, which would not be appropriate for this patient?
B.
B,
Really
absolutely.
contracting test.
Yeah, well, I don't want her to contract. So write that down. Placenta previa, I don't want her to go into labor. I don't want her to have contractions. Now I might do weekly biophysical profile because I'm looking at the baby, the amniotic fluid, the movement of the baby, and heart rate. So I might do that to make sure everything's still okay. She'll have bed rest. Yeah, because I don't want this lady getting up and bleeding. She can get up, and we give them bathroom privileges because women, it's hard to pee or anything on their bedpan, and you do more damage trying to get a patient to go on the bedpan than it is just to get them up with bathroom privileges. And of course, I'm gonna have a consent for cesarean delivery because this patient will have a cesarean delivery. Is
Okay,
everybody clear? Is everybody clear on placenta previa?
I have a question, not
Sure.
really a question. Can you go back to if the patient has an hemorrhage, what, that slipped me a little bit, that explanation. Can
Which
you
one?
repeat that for me? If the patient has an hemorrhage,
Oh,
can you repeat that
hemorrhage.
for me?
Oh,
Yes.
you want to go back to the hypovolemic shock?
No, it was for placenta previa.
Oh, placenta previa. Oh, sure.
Yes.
All right. So yes, she can hemorrhage. If you have a patient who has a placenta, say here's your placenta, right? And you have
Mhm.
and it's presenting right here. Okay. And she starts contracting on you. Then this cervix opens up more blood's going to come out because this placenta is going to just shed. It's going to bleed. And placentas are very vascular. It's a lot of blood because the placenta has to do a lot of work. That's the lifeline to that baby. So it's very bloody and it would shed, and she would hemorrhage. There's no doubt about it. And then you would have a patient that could go into hypovolemic shock real easily. So do I want this lady to contract?
No.
No. So this kind of patient, while I'm here, I might as well say it too, this patient here would not be a patient that I would induce labor. No, you never induce labor on a placenta previa because she will hemorrhage. Barbara, does that answer the question, hon?
Yes, ma'am. Thank you.
Oh, you're welcome. Okay. So my next area that I want to move on to is abruptio placentae. Okay, or an abruption. It's just the way it sounds too. Think of abruption. Abruption is something that is forceful. So write that down, forceful. So if something's forceful inside your body, is that going to cause you pain?
Yes, sure.
Yeah, it's going to cause you intense pain. And these patients come in with pain and they're doubling over and they have bleeding. But of course, this bleeding is going to be a little bit different because it's higher up. It's dark red bleeding. So let me show you where this is. So see here, you have your placenta. And see here, a hematoma has popped up. That hematoma is going to create a barrier right in here, see? So it's now pushing that placenta away from the endometrium where it should be. So here, the placenta breaks away and it's going to bleed now. This is not good. This is an obstetrical emergency. And so you can see the amount of bleeding. See, this is all blood. And it's dark red because the bleeding, the source of the bleeding is higher up in the uterus. Okay, that's the difference. So it's higher up. So when blood, that's usually bright red, mixes in with oxygen, then it turns to dark red. And so you got dark red bleeding here, and this lady can hemorrhage. Now, this baby is at definitely risk to die. Okay, because it needs the nourishment, the blood, right? The oxygen from the placenta. So here you have this breaking off the wall. Baby's going, what's going on inside here? And so mommy comes in, you put her on the monitor, and you got to feel a heart rate maybe in the hundreds or even 90s when you discover. And then you touch her belly. We're going to touch her belly to put the monitor on, and and as soon as you touch her, she's going to scream at you, and you find that she's got a rigid, write this down, rigid board-like uterus. That will be on exam number 1. She's got a board-like uterus. Okay, it is hard, just the way the word is, abruptio is abrupting off that endometrium. It's coming off that wall. It's going to be painful. And your uterus is going to have a different look to it. It's not going to look such a nice shape like we see. It's going to be more globule. So you can see where it's putting like an extra layer, you know, it doesn't conform to what it should be looking like. Why? Is because it's filling up with blood and it shouldn't be. And it's because this placenta should be right here against this endometrium. Now you have this like big cut inside. And so, yes, she's going to bleed. So with a abruptial placenta, you're going to get painful, dark red bleeding. That's what I want you to make sure you write down. Painful, dark red bleeding. All right. Got to get that baby out. This is an emergency. And, you know, in L&D, we do our own C-sections. So this kind of patient comes in. I see that she's abrupting. I hit the buzzer and tell my rest of my team I have an abruption going on. And then we come in and we get the baby out. Now, both of these have their own complications and risk. So your placenta previa could be, you know, if she has infection going on. Remember I talked about the chorioamnionitis and the those are infections that involve the uterus. She could have more of a hemorrhage after delivery with placenta previa. And you say, well, we got the baby out. She should be okay. But she's more prone to a hemorrhage. You know why? Now think about it. The placenta has been laying low in the uterus for a while. So it's made all that muscular tissue down there weaken. It weakened. So what happens is that you're going to have weaker contractions after delivery. So therefore, she is at risk for a postpartum hemorrhage. So when you have her back, she may be in the recovery room. Maybe I would recover her for 2 hours to make sure, you know, that we don't have this problem and her uterus is able to handle it and will contract the way it should be. But I'm always thinking she could have weak contractions. So I'm going to watch her. Now, so that's her risk and complication. My abruptial placentae, you know, if you have somebody who's hypertensive, okay, and you know, you have more blood volume, more pressure inside, you're going to have more risk for the placenta coming off the wall, creating a hematoma and abrupting. So hypertension, preeclampsia, eclampsia, definitely you have the uterus can abrupt. Now, if a patient is taking cocaine and they walk in your door, you can abrupt, definitely can. And alcohol use, that means, you know, they have a lot of, they're alcoholics that come in. Again, it affects the placenta. Again, it can cause them to have an abruption. Cigarette smoking or nutrition. This is a complication of placenta abruption. Another one is trauma, guys. A blow to the abdomen. You know, maybe she is living in a bad situation. She's a product of intimate partner violence. Her significant other gives her a big blow, punch in the stomach. We see that, unfortunately, and that can cause that placenta to weaken and eventually abrupt off the endometrium. If she's had, this is maybe her second pregnancy, and her first pregnancy, she's had an abruption, that's like, hey, a red flag. We've got to make sure her blood pressure is under control, make sure she's not smoking, make sure she's eating right, no cocaine or alcohol use if she has any kind of history. You go over that with her. And of course, a folate deficiency is never good either and can cause them to abrupt. So let me go to another brain teaser. And then I'll give you a 10-minute break in just a minute. A 33-week pregnant woman is in the emergency department with painless vaginal bleeding. Okay. What nursing action is contraindicated? So when you see painless vaginal bleeding, what is that?
Placenta previa.
Previa. Placenta
Previa.
previa.
Exactly. So which nursing action here is contraindicated. That means you
Or
would
you
not do it.
don't do a vaginal exam.
Exactly. You don't put your fingers up there when you have a previa because you can cause her to hemorrhage. Okay, I'm gonna stop right here. It's 4:31, and I'm gonna give you a 10-minute break, and we'll come back. This was just another slide that I went over with pain, and we already went over that. But that's how you distinguish one from the other, is the symptom of pain. Okay. All right. Okay. And then we'll come back in a few minutes, in 10 minutes. So have a little break. And then we'll come back, okay? I really want to get through everything. It's such good information. So come back in 10 minutes. I'll be here. And if you don't need to go away, then if you have any question about anything, you feel free to please ask me.
Professor Dunham, did you see the recent headline about one of the hospitals in Reading, PA? They were sued for 32.5 million for an injury that happened during birth because they failed to detect fetal distress.
Oh, no, no.
So the boy was born with
Ugh.
hypoxic ischemic encephalopathy, however you say that,
Yeah.
because they didn't treat that one infection with antibiotics.
Oh my gosh. Was it choreo? Was it what kind of infection?
It was the choreo one.
I told you. I tell you, they are really bad. That's why I went over that diagram with you to show you the chorion and the amnion, because those infections get ascending and they get in there and they can do a lot of bad things, a lot of damage.
Yeah, and I guess they should have done a C-section and they didn't. They had her deliver vaginally.
Ah, oh,
So
why? Where is this? In Pennsylvania?
in Reading
Oh my
Hospital.
gosh. I need to
I
go there.
can, I can, if you want to read about it, I can email you the link.
Okay, yeah, sure. Yeah, I'm always interested in that. I tell you, you gotta be on top of this. Things happen in OB so quickly. I'm gonna tell you, I always told my nurses, and I've been over a large amount of nurses. You don't come into the unit thinking it's okay, it's just another day. Okay? No, 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 no. The day that you come in thinking that, and any kind of unit, guys, and you get very complacent, is going to kick you right in the butt, because you always got to be on top of your game, always, no matter where you work. Things change in an OB. 1 minute your fetal heart rate could be like, say, 140s, and just like that, 2 minutes later you got in the 90s. You could have a prolapse cord. Say she was doing fine and her bag of water is intact, and all of a sudden her bag of water breaks, and all of a sudden you got fetal heart tones down the 90s. Okay, you got prolapse cord. Okay, I mean, we work fast in labor and delivery, real fast. So just like that poor little baby that was born up in Reading. Oh, thank you for sharing that with me. Yeah, that makes me sick when I hear things like that can be avoided. So they're suing for 32.5 million.
It was awarded right after the opening statements. There was no trial.
No trial. Just write the check. Yeah, yeah, yeah. Yeah, I've seen cases where I would say just write the check, because if you do something like that, so blatant, yeah. And that's why every nurse that works in labor and delivery, we're all certified in fetal monitoring. We're reading, that's the baby. The baby's trying to talk to you through the fetal monitor. And when we get to labor, I guess next week or the week after, we go over fetal monitoring and what all these different type of strips, deceleration, accelerations mean. And that's how the baby talks to you. And the nurses at bedside have to be astute to that. I mean, they pick it up quickly. Oh my goodness. Yep. There's no need for that. I'm going to tell you, that really gets me. There's no need for a baby to have brain damage due to people not paying attention. Yeah. Should have that baby out. Okay. All right. Well, you can see that kind of gets me going a little bit, because I don't like anything to happen to my babies. All righty. Let's go back. Anybody? Okay, so we did a lot of information so far. Anybody have any area that maybe they're not sure of, or they want a little more clarification? Are you good so far? Okay.
Yes.
Okay. All right, then I'm going to keep going, because we got preeclampsia and eclampsia and RH incompatibility, and we have the erythroplastosis, fetalis, and macrosoma babies, big babies. Okay. Those big babies, macrosoma, just let me put it in this way, over 10 pounds, I like to see them a cesarean delivery. All right. Because I just seen too many babies with shoulder dystocia where the head comes out, but the rest of the body you can't get out because you can't, the shoulders won't pass. Been there. It's not a good feeling. Okay, all righty, let's go. I'm gonna share my screen again, but you guys keep, Haley, I hope you're back. Come on, everybody back on the camera, otherwise I have to remove you from the, yeah, there's Ashley, she's back. Come on, Haley.
Sorry, my phone died. I'm sorry. I apologize.
Okay. Yo, that's a, hey, Ashley, thanks for saying that. Guys, next week for your exam, make sure that your computer, your cell phone is all, they plug-ins or they're well charged so you don't lose any kind of power during your exam. Please don't lose power during the exam. Oh, that would be horrible. Okay, so let's share the screen. And let me see where I was. All right. Okay. All right. So, where did I leave off here? Okay. So here you have a patient that does have excessive bleeding. So again, in any patient that's bleeding, med-surg patient, you're in the, maybe you're rotating to the emergency room. You're always going to chart the blood loss.
You left off on the pain slide. The
Huh?
nurse, you left off on the pain slide. Nursing.
I know I kind of went over that real quick, but I'll go back. I'm good. So pain. So we've got placenta abruption, abruption of placenta, and we got placenta previa. The main thing that kind of gives you a clue, and this is what you want to read in the question, is the topic of pain. Okay, it distinguishes them from each other. So abruptio is painful. Just think abruption. You know, you think of anything abrupting. You know what comes to my mind when I equate it with something else? It's like a volcano that's abrupting. You know, abruption. Wow, it's painful. It's a lot. And then placenta previa would be painless because the placenta, the problem with that is the placenta is laying low in the uterus, is right over that internal os. And so it's not causing any contractions. No, it's just it's laying there. It said, you know, I want to find a new home. And I found my way down to the lower segment of the uterus. So here I am, guys. I'm just hanging out there. Okay. I'm not causing any pain to my patient. But if she has a contraction, you might see some bright red bleeding. Hey, that's me, placenta previa. Okay. All right. So let's go here now, taking care of the patient with having bleeding. So you always want to do the vital signs because remember, hypovolemic shock is she's going to have increased pulse. Okay, the increased heart rate. Okay, she's going to have increased tachypnea, increased respirations. And then, of course, your blood pressure will go down. And then kidney function. So you want to include your intake and output because I want to know the kidneys are putting out what they're supposed to be. Okay, less than 30 mLs per hour, we got a problem. Kidneys are going, they're going down. All right, then you always want to observe for pain, like we talked about, and uterine rigidity or tenderness. That would be your abruptios. And a pain is your abruptio. Verify that orders for blood typing and cross-match have been carried out. Absolutely. So, you know, you're going to get labs when a patient comes in. So, you know, you're going to do a CBC. You may do some blood clotting factors because she could have low platelets and would set her up for a DIC. So I'm going to make sure that I do a blood clotting. Okay. I'm also going to RH, get an RH factor if I don't have it. I'm going to type and cross for you. Usually we type and cross for 4 units of packed red blood cells. And then, and they get that, you know, the blood bank band, we put it on them. And it has their number on and everything. So when it comes time for blood, then she's already banded. And then when the blood comes up, then you compare what's on the bag to the bracelet, and it's, you know, it's a big, you know, procedure when you have giving blood. I'm going to have an IV going, absolutely, and usually nurses can put an 18 gauge angiocats in. That's a pretty big angiocats, pretty big. The reason why I want a big one is so that if I need to get blood, that it can go through correct. There'll be no hemolysis for that blood going through a small catheter. You couldn't do it, okay? Anesthesia is the one that puts in the 16 gauge angio-cats, 16. So maybe you got a patient, like I had one day, I had a patient that went into DIC after delivery. And I had to get 18 gauge in her in anesthesia when we were giving her like all kinds of blood and IVs and platelets and everything. We had like 3 IVs going. Anesthesia puts in the 16 gauge. Okay. You always want to think, do I need, we're going to go into surgery. Maybe she's got a uterus that you just it will not firm up. It's boggy. She's hemorrhaging. And so we may have to do a hysterectomy if we had to. So we always thinking, maybe I have to take it back for surgery. If she's still pregnant, we're always going to monitor fetal heart rate and contractions. Okay. Anyone with excessive bleeding. Because when she has contractions, it'll make her bleed more. So if she's a previa, placenta previa, if she comes in and she's having contractions, we want to stop those contractions. Okay, we're not going to have her in labor because with contractions, it would cause her to bleed. You always, when you get your lab results, you're going to look at all your blood and so see her hemoglobin hematocrit, she's anemic. Look at your coagulation studies that she have. What's her platelet count, her fibrinogen count. You're going to give her oxygen by mask, usually about 8 to 10 liters via tight face mask. And then when you have somebody who has bleeding, you have either abruption or you have a previa, you're going to have the neonatal team in the operating room, okay? Because we always have to think, mommies have been bleeding and having this problem. My fetus is going to come out pretty low APGAR, will need resuscitation. So we want to have the team ready to go. Okay, so now we're going to go on. We're going to describe some antepartum complications of treatment and nursing care and discuss the management of medical conditions during pregnancy. So what's our first one? How about hypertension? Absolutely, because this will be on exam number 1. Gestational hypertension. So you have preeclampsia. Now we treat with magnesium sulfate. We discussed this in the beginning of class today. It's great because it affects the central nervous system. So you're giving magnesium to prevent seizures. Okay. Now write that down so you don't think you're giving preeclampsia for her blood pressure. No. But when you take down the central nervous system, are you not taking down blood pressure? Yeah. But we don't give it for the blood pressure. We give it to prevent a seizure. Okay. Everybody got that? Okay. Now the eclamptic patient, that's the preeclamptic patient that had a seizure. So say that patient, like I told you before, was coming up the elevator with the paramedics and she was already seizing. She was already in eclampsia. So I knew that patient's very sick. Okay. I mean, there I am with the magnesium ready to put into her 4 grams loading dose. But I knew she was already seizing. But I knew this patient now could be set up for what we call HELP syndrome. That's HELP, HELLP. Okay. So H stands for hemolysis. The EL stands for elevated liver enzymes, and the LP stands for low platelets. Let me tell you, that's a really sick patient, a patient that has HELP syndrome. All right, now, another patient that could have a terrible problem during pregnancy is somebody who comes into your clinic and she already has hypertension. She's already, her blood pressure on your first visit could be 140/90. That's a red flag. She's chronic. She's a chronic hypertensive patient. So we're starting out with already a problem. So we might have her on some blood pressure medicine. And then when she gets closer to 20 weeks, am I going to be watching for preeclampsia? Because that's when preeclampsia shows his dirty side of himself, or got his, there he is, because preeclampsia starts after 20 weeks. Write that down. 20 weeks has to do with the placenta. The placenta is now functioning on its own. So it happens after 20 weeks. Okay. Another indication that she's got a problem is she's spilling urine, a protein in her urine. You shouldn't have protein in your urine. So if you have that, then it means now we have kidneys. So we have hypertensive and we have proteinuria. Those are your two big signs that we got a problem. Okay. Thrombocytopenia is low platelets. That can happen. So she's now what we call, I don't know if you heard this before, the expression before, like a free bleeder. You know, she could be bleeding out of her nose. They usually, they could be even have, you know, spill some in their urine. They have low platelets. They don't have the ability to clot. That's pretty bad when you're dealing with someone who's hypertensive. So remember I said at the beginning, that first visit, you want to get a blood pressure. And so we maybe start out with a person who's got a blood pressure, say, let me write this down. Let me see, 110. Okay, over 70. And now on the second visit, okay, so that would be about 10 weeks. And then so 14 weeks, she comes back in to see you, and she's got a blood pressure of, say, 130 over 80. Okay, so she's escalating. That's why that first blood pressure is so important. Now she comes back in 4 weeks, and now she's closer to almost 20 weeks. So she comes back at 20 weeks pregnant, and now she's got a blood pressure of 150 over 90. Now we see that she in the range for preeclampsia. Plus, you test her urine, because we always test the urine when they come in, and now she's spilling protein. This lady is now flagged. She is high risk because now she has developed preeclampsia. Got to watch her very, very careful and watch the fetus. All righty. So here I have a little question for you. So you have a woman who is 35 weeks pregnant, okay, and she's been diagnosed with preeclampsia. Her blood pressure is 140 over 100, ranges to 160 over 110 millimeters of mercury. She reports have headache, has generalized edema, and has 3+ proteinuria. What would be the most appropriate environment for this woman to be in? Anybody?
Would it be two?
It'll
I'm
be
not
two.
sure.
Yeah, she's gonna be in the hospital. You're gonna give her a private hospital room with bathroom privileges. The reason why you're gonna have private is with a preeclampsia, you want to decrease her environment. You don't want to have her in a ward, or have a partner, anybody in the room. You want to have a very low key environment, kind of quiet. If anybody aggravates her, they don't come back. I used to have to throw out people because they started talking and kept talking about all the things that weren't even important to the patient, and they were just being annoying. And when that was annoying my patient, she wouldn't say anything, but her blood pressure was going up. I said, everybody in this room, out of the room, because she needs a low environment. You want to decrease the stimulation in the room. Okay. All right, some risk factors. Now, it does happen in the first pregnancy. Okay. It happens more in obesity, women who come in with already being obese. A family history. remember that first visit I said we're gonna get a family history? I wanna know, Mom, did your mother have hypertension during her pregnancy? If my patient's over 40, definitely, she's at high risk for gestational hypertension. Some books even say over 35 and under 19. Absolutely, under 19, that adolescent group as a risk for gestational hypertension. If they're having twins or triplets, again, yes. And chronic hypertension, of course, because they're coming in already with it, so they definitely have a risk for that. If they have chronic renal disease, already have a problem with their kidneys, they have to be very much watching out for gestational hypertension and for diabetes. Okay. All right. Let me see here. Okay. Now, these are systems, excuse me, that are affected by gestational hypertension. All right. Well, you got edema, you got high blood pressure, you got swelling. You see it more, guys, in the hands and the face. That's where you see it starting. I had a patient long ago in St. Luke's Hospital that had her feet absolutely she had elephant looking feet, elephantitis we call it. Her feet, you couldn't see her toes anymore. Okay, you know how an elephant's toes are? They're just like little stubs at the end, and you have all this massive amount of tissue on top. Well, that's what my patient looked like. She was just massively filling up with fluid. She was pre-eclamptic, and we're giving her lots of magnesium to try to, and we're watching her kidneys especially. Blood clotting, absolutely. Again, they can have low platelets, central nervous system involvement. You get the brain involved, we got a big problem. Eyes, blurred vision, spots before the eyes. They can lose. Some patients have lost vision. Urinary tract. We talked about the kidneys. Respiratory system can be affected by gestational hypertension. And of course, your GI system and your liver, because you can get epigastric pain. Epigastric pain is caused by an enlarged liver. And you see that on lab when you have elevated liver enzymes. Okay. So you got to manage it, because why do I want to manage it? Because I want to maintain blood flow to all her vital organs. Okay. That's the main thing. Got to keep this lady alive. And also I have to keep the baby alive. So I have to keep blood flow to the placenta in order to keep oxygenating this baby. And again, you want to prevent the convulsions. You don't want to get the brain involved. So magnesium. All right, you got it. Got magnesium sulfate. We talked about calcium gluconate already. It does reverse the effects of magnesium sulfate. And in some cases, we have given like labetalol to these kind of patients, and if they don't respond with their blood pressure going down, we have to do that. We're going to keep an eye on the fetus. You do that by doing a non-stress test, where I'm looking at fetal accelerations with fetal movement. Always monitor blood pressure. You're going to do daily weights in the morning and checking the urine for protein. And yes, you're going to check quite often to make sure, because at any time your kidneys can stop functioning. So you're going to have kidney function tests also. Okay. Let's see. Let's go into bleeding incompatibilities. Also on exam number 1, you'll have a question. And what happens is that, remember in the beginning, we went on the lab work, we wanted to know her blood type. I'm looking for that RH component, okay? So RH negative is a recessive trait, gets passed down. And then you have your RH positive, which is your dominant trait. Now there's quite a few people out there that do have RH negative blood type. But when you're pregnant, that presents a problem. because your fetus is usually Rh positive, because that's a more dominant trait. So if you have an Rh negative mommy and an Rh positive baby, okay, negative and positives don't get along. I'm going to tell you right now, they don't like each other. So it's a very bad condition and has to be, and you have to be on alert. So in the beginning of pregnancy, I find out she's Rh negative. So that tells me that around 27 weeks, we're going to give her RhoGAM or RhD immune globulin, or RhoGAM. RhoGAM is given because when you have fetal Rh positive blood that gets into mom's system, mom's circulatory system, the mom's system is smart. It's going to respond to these Rh positive blood coming in, and they're going to make antibodies. I always think of antibodies like little warriors inside your body, you know, they're going to get everybody. Boom, 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 you know, little warriors. So you take these antibodies and they're going to go after these beautiful Rh positive erythrocytes or red blood cells. Okay. It's because they don't want them there. They don't belong there. Mom's blood is negative. So I can't have somebody coming in that's positive. So my little warriors are going to go, the antibodies are going to go, boom, boom, boom. You can't be here. Okay. What happens then is that the poor babies, Rh positive erythrocytes, go down in the count. Okay. They go down. And so babies can get very anemic. And that's a condition called erythroblastosis fetalis. And I think I have a picture here. And this comes right out of your textbook. It's a great picture. You can see up here. Here's the Rh positive red blood cells. Okay, here's baby. Okay. And don't forget, mom and baby, you know, they do, you know, mix with their bloods, you know. And so mom, you know, gives blood to baby and baby gives back, but they have the placenta barrier. But when we have some leakage, that mom's now, her, you know, her negative is mixing in with baby's positive. Then you have these warriors called antibodies that cross that placenta. They go, okay, we're going to knock out these beautiful red blood cells. That poor baby then has a decrease in RBCs or erythrocytes and can be very anemic, severely. That's why it's called erythroblastosis fetalis. That's the condition. Now, there have been very successful intrauterine blood transfusions, okay, where they'll take out baby's blood and put in new blood. It's very risky. That's only because they want to save the baby, okay? So it can happen. And so this is called erythroblastosis fetalis. So we as nurses recognize this. So we say, oh, doctor, your patient is anti-Rh negative. So he goes, okay, be sure to give her RhoGAM, as I said, around 28 weeks gestation. Now, that protects this little baby from these terrible antibodies, okay? Now, after she delivers, now listen up, after she delivers, you can give another dose of RhoGAM, and that's usually 72 hours after delivery of the baby, okay? Now, when she has, I remember we talked about the amniocentesis, because there's a risk that there could be some exchange of blood, she'll get RhoGAM after that amniocentesis, because there is a risk of mixing of blood. So remember, negative doesn't like the positives. They don't get along. So the antibodies, mom's antibodies, going to travel over and going to knock down those beautiful erythrocytes. Baby can get anemic, and we can take care of this by giving her RhoGAM. Now I know that's on your exam, and also HESI likes to put this on their tests. And you'll see it a couple times. So you give Rogam twice at 28 weeks and then after delivery, but usually around 72 hours. Okay, so that was your RH incompatibility. And now we're going to flip into diabetes, because this is another medical condition that gets kind of complicated. And so you have your diabetes, you have your type 1s, and you have your type 2s. And we have our own in pregnancies called gestational diabetes. We do a screening test around about 20 weeks gestation. Now, if she's a type 1 that's coming in and she's pregnant, we'll do it sooner. I thought I'd say that already, but they come in sooner. And a true gestational diabetic glucose, after they deliver, the body will regulate itself and will switch back to a normal blood sugar, and her gestational diabetes is over. It's called gestational diabetes because it's during pregnancy. And don't forget, the placenta puts out its own, pregnancy hormone. It was placenta glycogen. So again, that is another way that she can come down with it. It happens. So effects on pregnancy on glucose metabolism. You have your hormones. You have estrogen, progesterone. You have your insulinase, which is an enzyme, and you have decreased prolactin levels. Now, the prolactin is the hormone that you need for lactation. So of course, that's going to have to do with glucose metabolism. So what it does, you have this increased resistance of cells to insulin. Because remember, insulin is made by the pancreas, and sometimes you have the resistance of the cells that are in the body. They resist the insulin, and sometimes they have increased speed of insulin breakdown. So that's why you could have this uneven glucose metabolism. Okay, so my next brain teaser, what would normally happen to a woman's blood glucose level during pregnancy? It goes up. Definitely, it would elevate, okay? Remember, and things in pregnancy, they don't usually decrease. As you noticed that, they escalate. It gets worse. And then you can have baby was born macrosomic. Now, a type 1 diabetic comes in. Her major risk for congenital anomalies is high because of the maternal hyperglycemic during the embryonic period development. So we see a lot of congenital anomalies for our type 1 diabetics, especially if they're not in control of their blood sugars, especially because during the embryonic, because that's when everything is developing, and everything needs to be in sync, I say, with everything. Okay.
So question, Professor.
Sure.
If the mom is currently on insulin, that means we would need to up her insulin then if
Yeah, we titrate it. Yeah, she's being watched the whole pregnancy, and we do blood sugars, and along with, usually I do my blood sugar on these kind of patients when I do their NSTs to make sure and go over and make sure they're going on diet. A lot of ladies during pregnancy with gestational diabetes are able to be controlled by diet. It's our type 1s that we keep close eye. And that doctor that I told you, that other part of our team is called the perinatologist. They also will watch these patients that are a type 1 diabetic, because usually they're on insulin pumps. And so then they just adjust their pumps, their insulin pump, according to the patient's needs and the gestational period. Does that answer? You got it?
Yes, thank you.
You're welcome. Yeah, it's quite fascinating, I think. I love taking care of these patients. It's quite fascinating. Okay, so what of my factors are linked to gestational diabetes? Of course, you probably would say, sure, obesity. They have a large infant, greater than 4,000 grams. That's a big baby, okay? That's about over 9-pound baby. And not only, I'll show you a picture of them, but not only they have a certain look about it. Let me show you this picture, because I think a picture is worth a million words. See my macrosomic baby here? Let's see here. Whoops, okay. You see how he's got like no neck. Poor little guy. He's got a big head. Imagine giving birth, vaginal delivery. You know, that's a big baby, guys. Do you see his shoulders? This would, you know, this baby, if the head got out, you know, probably with a 4th degree episiotomy. His shoulders, he's at risk for a shoulder dystocia. That's shoulder dystocia, dystocia. Big, those are big shoulders. And usually when we have a baby, and I've been on deliveries that has shoulder dystocia, they sometimes have to break the baby's clavicle in order for, when they break the baby's clavicle, they release that shoulder down and then we can get the baby out. So that's a big baby. Okay, so this is called a macrosomic baby. Macrosomic, large baby. You need to know that term. Okay, so going back to my other factors, she has a history of gestational diabetes and previous pregnancy. Again, that's why it's so important to get that obstetrical history. Grab it. What number of pregnancies for you? And we go to term and preterm. Well, I had a preterm. Well, why did you have a preterm? I have gestational diabetes in my first pregnancy. Bingo. The lights go off, okay? Because I need to watch this patient because she's going to be prone. And then we would do probably that fasting glucose test a lot earlier than we normally would. Okay, what's my treatment? You're always going to monitor the blood glucose level. So if you need to practice in the lab during blood glucose levels, do it in the lab. You got it in there. You can do it. I'm going to be looking at her urine for glucose because they would spill glucose if they had a large amount circulating, ketones, and then going to, you know, get out walking. Get outside, get out walking, get your shoes on. Let's go walking at least, you know, a little bit every day. And then, of course, I'm going to watch these babies, guys. You're going to do a non-stress test. Okay, this all I do is put the monitors on her belly, and I'm going to look at the fetal heart rate. Make sure the baby is in good health, fetal well-being. Okay. Let me scoot down to here. So the main thing that you have to worry about is when a baby's born to a mother who has gestational diabetes is hypoglycemic, low blood sugar. So a blood glucose level of 45 per deciliter is considered. Now, some books, let me put my little spiel here. Some books have 40. And some so maybe from 40 to 45. But if you've got a low blood sugar, your baby's in trouble. It's hypoglycemic. Now, these macrosomic babies are prone to that. That's why I put in bold letters here for you, because you'll see it again. These babies are more prone to hypoglycemic at birth. Now, think about it. If I was to feed you a Snicker bar every day, all day long for 9 months, your blood sugar would be high, right? Okay. Now, I deliver you. Okay. Now the cord is cut. Now you don't get any more of your Snicker bars. What happens to your blood sugar? It dips. It goes down. So that's why these babies are prone to hypoglycemia. And don't forget, we talked about macrosomic. I talked about shoulder dystocia. I talked about a broken clavicle. You have injuries related to macrosomic to this poor little baby being born. Okay, these babies should come out cesarean. It's easier for them, and they'll be monitored very closely. Okay, and then breastfeeding, it should be encouraged. Absolutely. All right, now let's go into heart disease real quick. You have an increased level, maybe some clotting factors. You do have a risk of a thrombus. You know, she could throw a DVT. Our patients in maternity can go into congestive heart failure very easily. Don't forget, you got increase of cardiac output 45 to 50%. Okay. She's got a big workload on her heart, okay? Sometimes a woman's heart can't handle that increased workload. So then she fills up with fluid, and you got a patient that can't breathe, okay? Congestive heart failure. If you have a patient with congestive heart failure, you have a reduced blood going to the placenta. Therefore, baby now is in jeopardy because mom is in congestive heart failure. So remember, these are your signs of congestive heart failure, and you can see these on medical patients. Persistent cough. You check lung sounds and they're moist. And then you get palpitations, you get pitting edema, and she has problems with breathing, especially on exertion, and she's fainty and she's very fatigued. And because of all this, because mom's in trouble, baby will also be in trouble. Okay, so what's your treatment? Well, going to be under care of an obstetrician and a cardiologist. Okay, it gets very complicated, and usually we try to get them to deliver. We do try to get a vaginal birth. It's preferred because it has less risk of infection or respiratory complications, and you don't want to put any more of a workload on this kind of patient. And next complication the patient can have is anemia. Okay, and we know what anemia is in pregnancy. It does have a tendency to go down. There's so much cardiac output increase. There's so much demands on the body. She can have nutritional anemia or genetics. A lot of times you'll see nutritional. They're not getting the right amount of foods to provide the support they need. And then you have genetic problems. You have sickle cell disorder, and you can have thalassemia. Both of these cause problems during a pregnancy because sickle cell affects the red blood cells. They're more of a looking like a crescent. They're not those nice beautiful concave red blood cells that you normally see. And then the thalassemia is a blood disorder that involves less than normal amount of oxygen carrying protein. If you have less oxygen carrying protein, then you're going to have less oxygen being circulated. Therefore, puts a problem with mom. Therefore, puts a problem with baby. See, one thing affects the other, and but we can handle it. We do. Anemia. They have a rapid pulse. They get very, very tired. Okay. I don't know if you ever had problems with anemia, but you get tired. You remember I talked about membranes, they're kind of pale. You get some shortness of breath, pounding heart. Not good to be anemic. We try to get them to take in iron. And please take note to this. Okay, vitamin C enhances absorption. You don't take iron with milk or antacids. That's a big HESI question. You'll see it again probably next week. So you don't want to take iron with milk or antacid. You have to ask her. She said, I have some heartburn. Can I take a Tums? Can I, what can I do? I usually take Mylanta, which is an antacid, right? Okay. So if they're anemic, you don't want them to take it because the iron will not be absorbed as it should be. So you want them to iron to be absorbed. So you have to keep away from it. So a glass of vitamin C. Okay. All right. Got it? Okay. All righty. Let's go on here. This goes over folic acid deficiency anemia. Not good. Remember, we want to prevent this. So daily supplement of folic acid would help. Okay. You need folic is essential, guys, for normal growth and development. So do I need this? You certainly do. Does she need folic acid supplement? She does. So there you go. Okay. I kind of went over sickle cell already. I put it in here and kind of, if you didn't have sickle cell yet in Med-Surg, it kind of gives you a little bit of explanation what it's all about. And main thing with pregnancy is that they do go into crisis, and we have to treat them, bring them in, and give them blood or give them fluids so that they can keep circulating what they need to circulate, so carry good oxygen to mom and baby. All right, let me see here. Let's see. So you're probably interested to know what's the nursing care. Again, take your iron supplements. Don't take antacids with the iron. You know that stools will be dark green to black. Okay. Teach them prevent dehydration. Okay, and activities I call hypoxia. You know, if you get out of breath, sit down, please. Especially someone who's anemic, because then they could go out on you. Okay. And somebody who's anemic, they need to report any kinds of infections very quickly to you. Okay. Another area I want to touch upon before we go is infections. Okay. So this is an acronym. It's called TORCH. It's to describe infections can be very bad for the fetus or the newborn. So toxoplasmosis is caused by eating raw meat. Okay. Or if she has a cat, they have a parasite called toxoplasmosis, and it can cause terrific damage to the newborn. Then under O is any other infection. And the big one I want to talk about is rubella. Rubella is not good. Remember I said in the beginning, we want to know if she's immune to rubella. If she's not immune to rubella, you cannot give her rubella injection during pregnancy. Never, never, never. You never give a live a vaccine to a pregnant woman. So what you do, if she's pregnant and she needs rubella, you're going to wait to after she delivers. You can give her rubella after delivery, before she goes home. And she's fine. Then she'll recover. And then she can even breastfeed, but you don't give it during pregnancy. All right. And then C was the cytomegalovirus. It's a very common virus. It's in the same family as your herpes virus, and is spread by direct contact of body fluids. Do we have a lot of body fluids in maternity? Yes, we do. So you have to be watch out for cytomegalovirus and, of course, herpes. Now, I think the next one's slides, I gave you explanation of toxoplasmosis and everything, so you can read those. And viral, I said, virus, viruses, there is no effective therapy, guys. A virus is a virus. You can't give an antibiotic for a virus. It doesn't work. So you have to be very careful with these with viruses, as we all know. This slide here just goes over the cytomegalovirus is the cause of congenital infections in newborn. Not good. Look at down the treatment. There is no effective treatments known. All right. So I've seen where women had to make decisions and having to have an elective therapeutic abortion because she was infected. Okay, because this is what it causes in a baby. These are major. These are major. So I know if you have that, your baby has that, there's no way it can be compatible with life. What I want you to get from the herpes virus is that type 2 is the genital herpes. If they have an outbreak, they cannot deliver vaginally. We'd have to go with a C-section, okay? And so because you don't want a baby coming through a vagina that's infected with the herpes virus. It can kill the baby, so you don't want to do that. So we want to make sure that we know if she has an outbreak and we can see it. Okay. All right. Now she can breastfeed if no lesions are present on the breast. Okay. Because you can get herpes on your breast. So you got to make sure that she doesn't have it. Okay. That's more explanation. This is about hepatitis B. I'll let you guys see that. These go over some STIs. I think I've gone over some of these with you when we talked about age-setting bacteria. Chlamydia is never good. Trichomonas, condyloma, acupata, that's, those are vaginal warts. They can all be transmitted. You know, once you got it, you got it. Okay, syphilis and gonorrhea. You want to know that. Remember I said in the very beginning of pregnancy, we're going to test for all this. This is why. Can't have a vaginal birth with that. HIV, we know what that virus is all about. It cripples your immune system. And of course, there's no known, well, we have better immunizations per se, but vaccines. We have more treatment today than we ever had. But remember something, this is what I want you to know. Heads up. It crosses the placenta. So if mom has HIV, baby is also going to be affected. Okay? So because it crosses the placenta. This is where she can't breastfeed because it comes through the breast milk. That's what you got to know too. So here, 1, it crosses the placenta. 2, you come in contact with infected maternal secretions at birth through the vagina. And then baby's going to get antiviral medications at birth and be treated, and mom will too. The sooner mom is diagnosed with HIV, she comes in that first visit and she has HIV, the sooner we get her on antiviral, the better it is for the fetus. All right. Okay, and here I go over another slide for you that I said breastfeeding is absolutely contraindicated. You would probably see that again. All right, and this, okay, so I already talked about the different infections on torch. I made some slides that go over each one, like toxoplasmosis and the treatment. The treatment is cook all your meats thoroughly and wash hands at all kitchen surfaces after handling raw meat. A pregnant woman should always avoid uncooked eggs. Well, I can't eat raw egg anyway. And then, of course, wash everything. And of course, a cat. When I ask them, they have an animal in the house, and they say, well, I have a cat. I'm thinking about toxoplasmosis on the top of my head. So that's where that comes in. TB. I made a slide on TB, so you have it. If the mother has active TB, the infant must be kept away from the mom until she's been cleared by the public health department. You know, you can have, they do a PPD test. You have your chest x-ray if your other one's positive, and you just got to follow up. We talked about urinary tract infections. It's under the infections here for you, cystitis and polynephritis. We talked about that. We talked about preterm labor. I think we're coming to an end. All right. The next couple slides are about environments and substance abuse and alcohol. Please read in the back of your chapter, toward the end of this long chapter we had discussed today, you have the condition fetal alcohol syndrome. I want you to read about that. These poor babies are born to moms who are alcoholics, and they do lose a lot of brain cells. And on page 116, there's a good picture of a baby born for fetal alcohol syndrome disorder. So take a look on page 116. And we talked about substance abuse also. We talked about all those. Okay. And trauma. I talked about trauma when I talked about placental abruptio. So, okay. And though it happens. All right. All right. Let's see. High-risk pregnancy. And these are all the above complications for about high-risk pregnancies, you know. And when you have a baby that's mom is sick, it's going to have disruption of the whole family. Finances will be difficulty. And of course, think about it. Baby gets whisked off to the NICU. And so you have that, that attachment, that bonding that's so needed. You don't have that. So it does a high-risk pregnancy, such as the ones we talked about today. They really do affect the pregnancy. And this last one I'm talking about is the grieving process. Please take a few minutes and read this slide and go about the grieving process, because all the complications that we talked about today, okay, they all have potential to have a bad outcome, all right? Every one of them. So, and every woman is going to have to go through a grieving. And so I used to make these little memento boxes. In a Florida hospital, we have them, and we have the white rose logo. And you want to give them privacy. You want to give them the memento box and let them grieve, you know, and you have a name bag, you know, name tag, you put it in a little box. Sometimes, you know, you ask mom, you want me to get a little lock of hair and put it, we have a little card put on that. Those all are very, very important to that mother, okay? This loss of a baby can affect her whole entire life. All right. Well, I want to conclude today. That was a very kind of a long chapter for you, chapter 5 on complications during pregnancy. So take a look, take a break now because you deserve it, and then take a look maybe tonight. Look again in the book on your PowerPoint. Please open your HESI review books. You will be very amazed at how much that will help you. Okay. All right. Have a good evening, everybody. It was a pleasure today. Bye-bye.
Thank you, bye.
Thank you.
You're
Question,
welcome. Yeah. Question.
when you were going over the HIV, would Abacavir be one of the medications used on a pregnant woman?
In a what medication?
Abacavir?
You can look that up and see what category that medication falls under.
I know it's more so to prevent the spread of it, but I don't really particularly.
No, we usually give medications, antivirals, during the pregnancy. And then, of course, if she is HIV positive, we give it during pregnancy. The sooner the better, because the baby can get affected, and the baby gets antivirals then when he is born, he or she is born.
Mm,
Look that up for me, okay?
yeah, I'll look it up.
Yeah, look it up. Send me a text message or send me a message or email.
Thank you.
You're welcome. Okay, I hope to see you tomorrow on the review. Okay, you all have a good night. I want you to be successful. I want you to make hundreds, okay? Okay. Bye.